Hi, my name is Dr. Greg Mader from RTI Health Solutions, which is a nonprofit organization focused on assessing the value and benefits of new treatments. I'm a senior health economist. In collaboration with Otsuka Pharmaceuticals, we developed an economic model to predict long-term health outcomes and time to end-stage renal disease for patients with rapidly progressing autosomal dominant polycystic kidney disease. Several key considerations were included in our study design. First of all, disease progression is characterized by eGFR decline, and total kidney volume is a key characteristic of patients with autosomal dominant polycystic kidney disease. Also, the age and sex of the patient are important when assessing their disease progression and predicting their long-term eGFR. Patients progress at different rates, so we really wanted, the model was constructed in order to be able to capture the different rates of progression, which no other published studies have shown to date. And lastly, we wanted the progression equation to be validated against long-term real-world data that includes patients reaching end-stage renal disease, just to ensure that what we're estimating within the model can be reproduced in the real world. So recently, European and Canadian working groups have identified the Mayo subclass classification tool as a key way to identify patients that are at a high risk of rapid progression. And they have identified the Mayo classification system and the Irazabal equation as key tools for assessing the long-term behavior of those patients. The model predicts eGFR decline for patients with rapidly progressing autosomal dominant polycystic kidney disease via the Irazabal equation and the Mayo classification system. So the patients are split up into 3 different subclasses based on the rate of progression: 1C subclass, 1D subclass, and 1E subclass, where 1C subclass progresses at a slower rate than the 1E subclass. However, all 3 of those subclasses put together are all rapid progressors. Note that there are 1A and 1B patients that are considered slow progressors that also have autosomal dominant polycystic kidney disease. So the model estimates long lifetime eGFR for patients that are in the 1C, 1D, and 1E subclasses. We know that patients remain in the same Mayo subclass throughout the model time horizon. The key result of our model is that although patients with autosomal dominant polycystic kidney disease can be separated into rapidly progressing categories of 1C, 1D, and 1E, lumped together they're all rapid progressors, but in fact 1C progressors progress at a different rate from 1D progressors and a different rate from 1E progressors. So for example, if you consider a patient that's 30 years old with a baseline eGFR of 110, the 1C patient will end up reaching end-stage renal disease in 25 years, whereas the 1E patient will reach end-stage renal disease within only 15 years. So in terms of their age at end-stage renal disease, that 1C patient would be 55 years old and the 1E patient would only be 45 years old. That's a 10-year difference for a group that were all lumped together the same. So a lot of increased healthcare costs and decreased quality of life has been reported for patients in later stages of chronic kidney disease and end-stage renal disease. So the treatment delaying time to end-stage renal disease would be very valuable from an economic perspective, where patients, if they remain in earlier stages of CKD, visit the hospital less and have a better quality of life. So this work was in collaboration with Otsuka Pharmaceuticals, who funded the research project.